Good afternoon, everyone. Welcome for the webinar series conducted by Faculty of Medical Sciences, University of Sri Lanka Staff Development Committee. So today, our topic is Thalassemia in Sri Lanka. Are we doing enough? So today, the session will be conducted and moderated by Dr. Dhammika Gunawardena, who is a consultant hematologist and a senior lecturer at Faculty of Medicine, University of Sri Lanka. So in order to conduct the session and introduce our speakers, I would like to hand over the session to Dr. Dhammika Gunawardena. Over to you, madam.
Thank you, Sajid. Welcome to all of you to the discussion of thalassemia, the most common genetic disorder in the world. Firstly, I'd like to thank the Staff Development Committee for allowing me to create this platform. I think as academics and clinicians interested in a topic, I think it's very important to create a platform consisting of people who are very involved in this. So thank you, Staff Development Committee, for giving me that opportunity. I think thalassemia touches us at every level, at at the level of medical students, level of lecturers, doctors, nurses, MLTs, and finally, most importantly, the public. So here we are with three speakers who are quite involved in today's topic. So first, I would like to introduce Professor Anuja, Senior Professor, who is no stranger to the Thalassemia Forum. He's a clinician dedicated to looking after hemoglobin. So he's a specialist in internal medicine, senior professor in medicine, University of Kelaniya. He obtained his DPhil Oxford in his work in hemoglobinopathy in 2002. He established the thalassemia unit in Marrow with currently about 502 patients over 12 years. And he's the first one to establish HPLC in Sri Lanka. That's in 2003. And of course, he has done a lot of research in the forum of thalassemia. The next speaker will be Dr. Sewandi, who is representing many hematologists who are scattered all over Sri Lanka, doing a great service in diagnosis, screening, counseling, and managing adult thalassemics. Of course, our pediatricians are huge strength in managing thalassemias because they contribute immensely in building up the thalassemia units and managing the children. So she's currently working in Tangol, but has several years of experience working in difficult areas such as Munaragala, Ampara, and has experience in diagnosing and managing thalassemias and sickle cell disease. And our pediatrician today is Professor Sachit Methananda, currently the Professor of Pediatrics and Head of Department of Pediatrics at University of Kelaniya, and a consultant pediatrician at Colombo North Teaching Hospital, Ragama, Sri Lanka. He's the pediatrician in charge of the Colombo North Pediatric Thalassemia Center, and he has several years of experience in managing patients with hemoglobinopathies. So in collaboration with Weatherall Institute of Molecular Medicine, University of Oxford, he has conducted several preclinical and translational research studies. He's also the principal investigator of the first randomized double-blind placebo-controlled clinical trial that evaluates the efficacy of hydroxyurea in children with transfusion-dependent thalassemia. So these are three speakers, and I think I'll have my first question to Anuja. So Anuja, I'd like to ask you about the history of thalassemia, how it all came about, the prevalence and studies that have been done.
The story of thalassemia in Sri Lanka is really a fascinating one because in the first documented case of a hemoglobin disorder dates back to 1950. And that honor goes to the famous pediatrician, Professor C.C. De Silva, who is honored for many things. He's one of the greatest pediatricians of all time, which he called Cooley's anemia, published in actually 1950. So this it's historically it's very important because the first case of hemoglobinopathy or thalassemia, which was called Mediterranean anemia then, was described by Thomas Cooley in 1927. So almost about 30 years after the first description, worldwide, Professor De Silva described the first case, first 4 cases from the Lady Ridgeway Hospital. And then in 1954, researcher by the name of Herman Lehmann, who was fascinated by studying sickle cell disease in India with another famed lady called Mary Catbush. He came down to Sri Lanka to study sickle amongst the Vedda population, because he was essentially arguing that the Veddas, being the tribal, the aborigine population of Sri Lanka, should be having sickle cell, because he had just discovered sickle cell amongst the a few tribal people in who were living in the so-called Blue Mountains, the Nilgiri Mountains in Tamil Nadu. So he was absolutely sure that the Vedas must have a link to the tribal people of the Nilgiri Mountains. But to his surprise, what he found amongst the Veda population was not sickle, but hemoglobin E. And interestingly, this was the 4th publication, discovery of hemoglobin E worldwide. And so by that time, beta thalassemia had been discovered, hemoglobin E was discovered. And in 1960, Professor De Silva, C.C. De Silva, discovered the first case of sickle. This time in Batticaloa. Again, he was fascinated by the discovery of sickle in Sri Lanka. In Sinhalese families in Batticaloa, and he was arguing that sickle must have come from the Africans who may have accompanied the Dutch or the British who may have landed in Batticaloa. At the times, Sri Lanka was under occupation by the Dutch or the British. So there was a lot of historical perspectives given to these hemoglobin variants. And then the other big figure in hemoglobinopathy field in this country was Dr. Nagesh Nagaratnam, physician by profession. From the time he was a very young doctor, a junior doctor, he started doing research in the field, and he was the first to discover a case of E-beta thalassemia in 1958. And he authored about 30 publications in thalassemia. At a time, there was hardly any laboratory support in this country. He was basically collaborating with researchers in Madras. But everything was, if you look at the period of 1950s up to the 1980s, thalassemia was exotic. You know, people considered thalassemia to be an exotic disease. Case reports, there were quite a lot of them coming up. No one really realized that thalassemia was a significant problem for patients until the legendary Professor Weatherall arrived in Sri Lanka in the mid-1990s, when the first ever micro-mapping survey of hemoglobinopathies were carried out in the country. And only then did the true story about thalassemia start to unfold in the country. And the rest, as they say, is history. Back to you, Damita.
Yeah, so that's very interesting, Anuja. So back to the epidemiology of our country. I know you were involved with a few studies on this. So could you elaborate on that?
Right. So with from the very beginning, from the 50s to the 1990s, almost all the types of hemoglobin disorders found identifiable in this country had been discovered by the pioneers. Professor De Silva discovered beta thalassemia, and sickle had been discovered, hemoglobin E had been discovered, and even there was a suspicion by a publication of Dr. Nagesh Nagaratnam that alpha thalassemia might exist, which was subsequently probably disproved by really looking back. But once you did the epidemiological surveys, where we actually did the micro mapping, we realize now that there are two things that you have to realize. First is the case burden. How many patients are there in the country? And the answer to that is the total number of patients with thalassemia or major hemoglobinopathies seeking treatment across the country is around 2,000. That we know for sure because we have done essentially unit to unit surveys. Unfortunately, even now, we don't have a national registry for thalassemia. So there's no automatic reporting of patients. This is one of the major problems we have in the day and age. We are talking of real-time data for even COVID. For a disease which has been in existence for such a long time, there's no registry for the true number of patients in the country. But we know through research that the total number of patients is about 2,000. Secondly, the number of carriers. Now, for the audience who know, I think thalassemia is a genetic disease which is transmitted in an autosomal recessive fashion. So there are these individuals who are called carriers who don't have a disease, but they have this hidden gene which is not causing them any harm. Those are called the carriers, or in Sinhalese we call them the Vahakiyo, who are completely asymptomatic. They may complain of symptoms, but very often if you really look into the reason, it's due to something else. But two Vahakiyas, or two traits or carriers marry, they produce a child. There's a potential for them to produce a child who have got a disease. So when you look at the burden of carrier rate in the country, that is huge. Beta thalassemia trait across the country, about 2.5% of the Sri Lankan population. Now, people might argue there's nothing called Sri Lankan population, but across the races, Sinhalese, ethnic Tamil, and the Moors, it is almost the same. Alpha thalassemia, the other important hemoglobinopathy, the carrier rate is much higher. It's about 10% of Sri Lankan population. Here, the Moors have more thalassemia, alpha thalassemia than the rest. And then the most important structural variant in the country is hemoglobin E, which is found in about 0.5% of the population. So in short, we have a lot of patients. Well, that's not true at all. We have few patients. We have 2,000 patients who are seeking treatment for thalassemia, but a lot of people who carry the gene for the hemoglobin disorder. This is the same across the world. There are about 700 million people across the world who have the gene for the disease, but the total number who have the disease is much less. I hope I'm making myself clear.
Yeah, I think that's a very important point, Anuja, because in a small clinic, hematology clinic, we detect quite a few thalassemia carriers, incidentally detected. And the message we need to give across is just get yourself screened, the younger population. Let's move on to diagnosis. So actually, Sewandi will be talking about diagnosis with us. And so talking about diagnosis, there are two issues here. One thing is to diagnose the infant with thalassemia major, And the second issue is diagnosing thalassemia carriers. That's probably a challenge because carriers are, healthy people walking about, and catching them is certainly a challenge. So Sewandi, could you elaborate on how you would set about diagnosing these patients?
Okay, so yes, and good afternoon, everyone. This diagnosis of thalassemia is not really a challenge actually, because it involves a readily available set of investigations that are found at almost all laboratories in the government sector of this country. Simply a full blood count is the starting investigation. And when considering the thalassemia major, it is a bit of a challenge because the patients present with severe anemia in their infancy at 3 to 6 months of age, where we need to get into a diagnosis before we commence their first transfusion. Because once they are transfused, they will be transfusion dependent throughout their lives. And we won't be having patients' blood for further investigations anymore. So the simply a full blood count, which will show severe anemia with hyperchromic microcytic red cells and numerous nucleated red cells in the blood film. As you can see in this HPLC screening, it's the confirmatory test for the thalassemias. You will see that these patients will not producing adult hemoglobin or HbA, which will be 0, and they will have persistently high fetal hemoglobin. And also you have to do the extended phenotyping of red cells before starting transfusion, because once they produce antibodies for the transfused against the transfused red cells, we need to match the blood for transfusion according to the patient's red cell phenotype. So for that, we need to get the red cells of the patient's phenotype before commencing transfusion. And of course, parental screening is important to detect that both the patients are carriers, and you can offer family screening to their extended family. On the other hand, diagnosis of thalassemia minor is quite I would say less cumbersome. You can take your own time because they're not very symptomatic. You find them incidentally, where you get a full blood count done for something else, like maybe an infection or before a surgery or in a pregnancy at your booking visit, that you will find that these patients are mildly anemic with a low MCV and MCH, which is comparatively too low to the full blood count. It is kind of a classic feature where your diagnosis leads to thalassemia in more than 90% of them. And also the classic blood film with hypochromic microcytic anemia and numerous target cells. But iron deficiency always remain at the corner with as a differential diagnosis, especially in the periphery where the iron deficiency is highly prevalent. Therefore, you need to exclude iron deficiency in these patients with a serum ferritin or by giving a trial of iron replacement in a fit and young patient. And once it is excluded, you can go for the confirmatory test, which is HPLC, or high performance liquid chromatography, where various types of hemoglobin in the blood is separated according to their chromatographic or electrophoretic mobility and it is quantified. And according to the changes in their normal quantities, like some will be increased, some will be absent, you come to a conclusion whether these patients are having a hemoglobinopathy carrier state. Once it is diagnosis, again, what is mandatory is offering them counseling and family screening. There are often gray areas or difficult or challenging areas in diagnosis sometimes, as in any aspect of medicine, where you need assistance, or maybe sending your samples to a referral center or get a second opinion where the medical research institute or always Prof. Anuja has been helping us with the genetic diagnosis whenever necessary, without hesitation and free of charge. Yes, that is regarding thalassemia minor.
I think let's get on to the pediatric problems. If we have Sachit on board at this moment.
Yeah.
Yes, Sachit. Yeah. So I know you're involved with looking after the pediatric population in Ragama. So what are the specific challenges you come across in managing them?
First of all, let me thank the staff development committee or the unit of the Sri Jawadanapura medical faculty for inviting for this talk, which I think is very, very timely and suitable. I hope you can see my screen. Let's try to share. Yeah, don't worry, I don't have too many slides. But as some of these who have joined our medical students, I will just briefly describe how a patient with thalassemia is being managed, which is quite straightforward when it comes to transfusion-dependent beta thalassemia major. As Sevandi has correctly sort of pointed out, we need to commence the transfusions as sort of soon because they will be presenting with very severe anemia. However, at the same time, it's very important that we make the diagnosis right. If we don't get the diagnosis right, we might not be able to pick a period where these children are being not transfused to revise our diagnosis. So first and foremost, the diagnosis of thalassemia is confirmed by HbA1c as nicely described by Dr. Sevandi. Once they are diagnosed with thalassemia, for normal medical students, is an autosomal recessive disease. Autosomal recessive disease where you have either carriers or patients, which is generally not the case because the genetic mutations of thalassemia are immense. There are about 300 mutations. One mutation is one that Professor Anuja pointed out, the hemoglobin E mutation. So because of the diversity of mutations, actually thalassemia is a spectrum of diseases. So although most sort of individual can have two abnormal genes of beta thalassemia, homozygous beta thalassemia, or we call them as compound heterozygous beta thalassemia because they will have two different mutated genes. So in the scenario, they may not behave as beta thalassemia major who will require monthly transfusion. So it's the most important thing for us clinician, and that's probably the most severe challenging thing to decide whether this patient, whether this child is a transfusion dependent thalassemia patient or a non-transfusion dependent thalassemia patient. If you have homozygous beta thalassemia, the answer is quite straightforward. They will invariably, most of the time, behave as transfusion dependent thalassemia. However, when you have hemoglobin E beta thalassemia, hemoglobin E beta thalassemia means in one of your chromosomes, you have the hemoglobin E mutation, and the other chromosome, you have the beta thalassemia mutation. The hemoglobin E will be produced to a reasonable amount, reasonable degree, so that your hemoglobin might not drop drastically to levels like 4 or 5. So hemoglobin E beta thalassemia patients can be in any point in this spectrum. If you don't transfuse, some of these children will have a hemoglobins as low as 4 or 3 or 4. Whereas some will have a baseline hemoglobin between 7 and 8 if you don't transfuse. So it's very important initial stages, maybe the first 6 months to see and to see whether these children, whether they can be managed as non-transfusion dependent or transfusion dependent thalassemia. That's a big, because if you put them on a regular transfusion regime, they will never be able to take out from a transfusion regime. So what we generally do is, this is not applicable to all patients with thalassemia, depending on the genetics. So it's important that we exactly know what sort of a genetics we have. We can sort of, especially if they have hemoglobin E thalassemia, we might consider not transfusing them for a certain period and see whether they will have a stable baseline hemoglobin approximately 7 without requiring transfusion. So these patients can be managed as non-transfusion dependent thalassemia and be given occasional transfusions when they require. Whereas if the hemoglobin continues to drop below 7 grams per deciliter in several occasions, they have to be managed as transfusion dependent thalassemia. If we are managing as transfusion dependent thalassemia, we have to do it properly. What we recommend is to maintain a pre-transfusion hemoglobin above 9. So you transfuse them regularly, 2 to 5 weekly, with the aim of maintaining a pre-transfusion hemoglobin above 9. Generally, what we do is to transfuse them up to 14 grams per deciliter, get them back in 4 weeks, and check the pre-transfusion hemoglobin. If it is between 9 and 10, we are very happy. We just continue in that management protocol. Whereas if we are managing a child with non-transfusion dependent beta thalassemia, especially hemoglobin E beta thalassemia, we will be regularly checking the hemoglobin, and we will not try to maintain a pre-transfusion hemoglobin above 9. We will try to maintain a standard baseline stable hemoglobin approximately 7 without transfusing these children, but they will have some degree of extramedullary hemopoiesis as well as bone marrow expansion. So those patients has to be individually managed. The why we don't transfuse these patients is because blood transfusions will invariably be associated with iron overload. Iron overload is the most troublesome problem that we encounter in regularly transfused transfusion-dependent thalassemia patients. So if I briefly take you through this graph, this shows the iron overload among our patients within the first 5 years, so for 16 years. You can clearly see initial 2 years, the iron will gradually go up. The only marker we have used here is serum ferritin, and that will be stable. The current recommendation, even the Thalassemia International Federation recommendation, is to assess iron overload by doing serum ferritin after the 10th transfusion or when they reach 2 years. But in practice, and even in this research study which has been published, what we have seen is in our patients, the serum ferritin goes above 1,000. Sort of, if you first check for the first time after 10 transfusions, it has probably reached about 2,000. So what we recommend and probably what we practice is to check the serum ferritin when they receive the 5th to 6th transfusions. So it's not really in the guidelines yet, but that's been practiced in many other countries to check serum ferritin when they are transfused for the 6th time, maybe even a younger age, and start chelation early age. What drug to give? We know there are 3 iron chelator medications. Desferrioxamine, which is only available in the parenteral form, subcutaneous or intravenous. Deferrasirox, which is as equally efficacious as desferrioxamine, which can be taken orally, empty stomach, early morning, dissolved in fruit juice, and this deferriprone, which is very rarely used. The 3 iron chelators available are desferrioxamine, deferrasirox, and deferriprone. Deferriprone has a lesser efficacy than the other 2 drugs, so it's not very commonly used. It has a preferential myocardial iron chelation ability. However, it's not that commonly used in our country. What we use here is desferrioxamine and deferrasirox. Both have equal efficacy. So in theory, if you read the books, they will say deferrasirox is not recommended below 2 years, but in clinical practice, if we are starting iron chelation, we sometimes even start deferrasirox in children less than 2 years when they reach 1.5 years, because the problem of iron overload happens before 2 years. It's not fair for pediatricians to put babies who are less than 2 years on a pump with desferrioxamine subcutaneous infusion that has to be gone for 12 hours at 10 to 12 hours every day, at least 5 days a week in a small child. I personally feel it's not fair. So this Deferrosirox is quite safe drug. I have been using, and it's also recommendations are coming, so can be started even at early stages. So the first line iron chelation medication is Deferrosirox because it's available orally. What challenges we have on iron chelation? There are multiple challenges. Being a third world country, we all face problems with the availability and the cost of medication. These drugs are extremely expensive, and although they are given by the government free of charge, the availability or the supply is not maintained. We have long patches of absence of drug. So we for about a couple of months, we did not have any iron chelator. So maintaining serum ferritin in the optimal level has been a challenge. The optimum serum ferritin recommended for thalassemia major or transfusion dependent thalassemia is less than 1000 nanograms per milliliter. So although we have drugs, although they are given free of charge, the availability is a problem. So it's a challenge to maintain serum iron in the desirable range.
Right. Okay, thank you, Sachit. Quite agree with you there. I mean, we do have heavily iron overloaded patients among adults also. So I think talking about adult thalassemics, most of the hematologists in the peripheries manage adult hemophilics, and so I think I'll direct that question to Anuja, who manages quite a few adult thalassemics and has quite a lot of experience on the topic. So over to you, Anuja. What are your experiences and challenges in managing the adult thalassemia?
As Sachit was trying to come into the topic, the problems of a thalassemic are essentially twofold. There is problems due to anemia, and that essentially lack of blood, and then there will be problems due to iron overload. The problems of anemia in a adolescent or an adult thalassemic would be disfigurement, and the so-called classic thalassemic phase. It is unsightly and unnecessary, to be honest, because if a child has been managed well, if the hemoglobin, the pre-transfusion hemoglobin has been maintained at 9 grams and above, this does not happen. If the pre-transfusion hemoglobin has been maintained at 9 and above, the child and adolescent subsequently will have no extramedullary hematopoiesis. Therefore, the large livers and the spleens and subsequent complications like splenectomy would not happen. And complications like leg ulcers and fractures, which we unfortunately see a lot in the adolescent and adulthood in thalassemia patients, are due to inadequate transfusion of thalassemics in childhood. Then comes the bigger problem, as Sachit mentioned, poor chelation, keeping the iron over 1000 would lead to 3 organ systems being involved. First to be affected would be the endocrine, second would be the liver, and if there's extensive iron overload, you will end up with cardiac damage. And this seems to happen in an orderly fashion. And in fact, the most common endocrine damage, in fact, the commonest consequence of iron overload in the thalassemia population is hypogonadism. It is lack of puberty or failed puberty in the thalassemia population. And this happens in about 40% of our thalassemia patients. And then short stature is another thing which we see so often. So to answer the questions of the physical problems of thalassemia patients, if they are not managed well in childhood, we inherit a group of people who are stunted, who don't have puberty, or who need support to attain puberty. So they have no ability or very poor chance of getting married and having children, and who run into lots of problems with other hormone problems, liver problems, developing cirrhosis, and having a premature death, either due to infections, partly contributed by having their spleens removed, or due to generalized reduced immunity due to iron overload. So it's a complex problem, and to mess things up, of course, there are huge issues of psychological issues, which comes with a long-term disease where the patients have to attend hospital from childhood. So it's indeed multitude of issues. And I must add another thing. Thalassemia in Sri Lanka and in many other parts of the world is still managed well by pediatricians or pediatric hematologists. When they pass a certain age, when they are past about 13, 14, 15, and 16, there's hardly anybody to receive them. So the adult thalassemics are lost. There's nowhere else for them to go. No physicians or the so-called adult hematologists receiving them are poorly prepared. Now, this is an area which needs addressing in this country pretty much urgently. Thank you, Dhanmi.
Thank you, Anuja. Now, I'd like to ask Sewandi, who has been working outstation for some time, to discuss about the challenges you faced in the outstation setup.
We do encounter the same challenges that Professor Anuja and Dr. Sajit explained in detail in managing both pediatric and adult hemoglobinopathies in the peripheral setup as well. So just to take your eyes away from thalassemia, I would say that I have been working in 3 most remote districts in this country during the past 5-6 years: Ampara, Monaragala, and Hambantota. This is where they are located, and they are quite large districts in land area with a large land area, but a lesser number of people. But they have their socio-economic, cultural, as well as environmental challenges in receiving as well as other. It's kind of a group of isolated people in the population in these districts. So this is where I work, the 3 hospitals. So this is how we diagnosed our hemoglobinopathies. There is quite a high prevalence of hemoglobinopathies in these areas with a big diversity. We get not only beta thalassemias, but all types of hemoglobinopathies. All these 3 areas have pockets of sickle cell disease, which is very important and which kind of mix up with all other types of hemoglobinopathies or beta chain disorders like hemoglobin beta, D, E, everything. So it's quite a diverse group of patients that we diagnose, and also we have to manage them all because of the distance to larger hospitals, or so-called thalassemia centers in Kurunegala or Ragama, where these patients are managed. Only hemoglobinopathy patients are managed, but our patients stay with us. So we do manage them as a multidisciplinary team together with the pediatricians, especially in the pediatric population, where Ampara has a separate transfusion day unit under the pediatricians, And these patients are transfused in the pediatric unit and in adults in the medical ward. And all these patients are being followed up at the hematology clinic. Pediatric population, of course, come during school holidays to get their iron levels checked and them chelation optimized and to get the scans done and the endocrine referrals, etc. But of course, we do get the challenges of not having adequate stocks of drugs, like we are not having desperioxamine at the moment, very scarce amounts, and also we were having a challenge of not having hydroxyurea some time back. And blood is also a challenging thing, although it was not before because of this pandemic. Donors tend not to come for donations, yes, so because of its diversity and the different way of behavior in each time, even the same disease behave differently in different areas. I must say sicklers at Hambantota are quite different from the sicklers at Ampara and Monaragala. The Hambantota people were quite behaving little bad than Monaragala. They are having frequent crises, painful crises. And also, I would say the pregnancies, all these areas, ladies tend to have children at a very younger age, and they tend to have more children. So one of the hemoglobinopathy patients are almost always pregnant and being followed up. So the obstetricians help us a lot in managing the pregnancies, as well as the transfusion teams. They without hesitation give us all types of blood with antigen negative blood, and they tend to cross match and make the blood leukodepleted and give the necessary blood at the necessary time. So it's quite diverse and quite interesting in managing these cases in the periphery with kind of remote facilities, and always the tertiary care centers like Sajit have been helping me with my patients, and also Prof. Anuja, they are readily available with their advice and taking down our patients for further care if when necessary.
Right. Okay. So, Vandika, could you just quickly elaborate on like the availability of bone marrow transplant in Sri Lanka?
Yes, bone marrow transplant is considered the only curative measure of managing the thalassemias. It is available in the country. There are 2 centers, but in the private sector, they have at the moment performed about 60 to 70 stem cell transplant in thalassemics, in matched sibling donor and matched unrelated donors, and they have an overall survival of about more than 90% and a thalassemia free survival around 85% according to the presented statistics. The government sector, there are 2 national transplant centers coming up at Lady Ridgeway Hospital and the National Hospital Kandy. At LRH, everything is complete. The staff is recruited and trained, and they're ready to start. Once the peak of this pandemic wean off, they will commence with their first stem cell transplant. They have their patients ready with donor workup completed, and they are conducting telephone clinics at the moment because they don't risk their patients coming down to Colombo during this dangerous period, I would say. And these are the pictures of their transplant center and the clinic. Kandy, of course, is still under construction, and but they have commenced registering patients, and their clinic is started. So that's where we are in transplant in this country at the moment.
Yeah, I think Sajit, would you like to talk about any other modalities of treatment?
Yeah, let me get Right. I hope you can see my screen and hear me clearly.
Yeah.
Let's put it in there. So although the bone marrow transplant is the only available cure at the moment anywhere in the world, it has also its limitations. So that's why new therapeutic approaches are being tested and researched around the world. For bone marrow transplantation to be successful, as Wendy said, it sort of the donor has to be fully HLA matched sibling donor. That's where you get the highest success rates, which is approximately more than 90%. When you don't have a HLA matched sibling donors, the success rate declines, although there are several other donors have been considered. In addition to the lack of donors, there is a transplant-related mortality, and the recipient can develop graft versus host disease. So there are some sort of certain morbidities and mortalities related to bone marrow transplantation. The most promising new approach for curing thalassemia is gene therapy. How does this work? Actually, thalassemia is one of the very suitable disease to develop gene therapy. We all know the problem with beta thalassemia is a defective beta globin gene. In theory, what we are doing here in gene therapy is introducing a healthy gene, healthy beta globin gene to hematopoietic stem cells of patients with beta thalassemia. If you look at the workflow, it's very straightforward. You would take out the hematopoietic stem cells out from patients with beta thalassemia. In the laboratories, you will insert the normal beta globin gene, generally using lentiviral vectors, and then as a routine bone marrow transplantation, this time it will be an autologous bone marrow transplantation. The cells will be transplanted back to the same patient. So you take the cells out, modified them in vitro in the laboratory, and put them back to the patient. So as an autologous bone marrow transplantation. When we compare it with the traditional hematopoietic stem cell transplantation, when you have bone marrow transplant, that will be an allogenic. Someone else's bone marrow will be transplanted. Whereas in gene therapy, your own cells will be transplanted back to you. So the cells are not foreign, so you don't need any immunosuppression, and graft versus host disease is not there. And more importantly, you don't need any other donors. Anyone with thalassemia can be a donor for his own gene therapy transplantation. So there are so many advantages of gene therapy over bone marrow transplantation, and if the gene therapy is successful, that will be available to all patients with beta thalassemia. However, it is difficult said than done. The technicality of gene therapy is difficult. Although we insert the gene into the cells, the gene might not function because we know there are so many other different things required for the expression of genes, like epigenetics and gene regulation function. So although the gene is inserted, the gene might not produce normal beta globin, or else it will produce a lesser amount of beta globin. However, the field is progressing. Actually, gene therapy for beta thalassemia has reached clinical trials. And this paper, published in 2018, presents the results of 22 patients who underwent gene therapy for beta thalassemia, and the success rate has been quite good. With this, gene therapy has been approved by the European Medicinal Agency as a standard treatment for patients with transfusion-dependent thalassemia who do not have donors. However, the cost is enormous at the moment, $1.8 million. However, we can be very happy that the gene therapy is an accepted cure for beta thalassemia at present, at least in the Western Hemisphere. The other option for gene therapy, which is now developing, is known as genome editing, where you will be modifying the exact gene at its location. So when you get standard gene therapy, you will be inserting the beta globin gene and that beta globin can get incorporated into the genome at a site that it likes. So it may not be the normal chromosome number 11 where the beta globin is there. When it is inserted into a different place, it will not function and it will not produce beta globin. Whereas in gene therapy, genome editing, you can edit the genome so that the whatever the targeted thing, target mutation or insertion of the gene will be targeted to the exact location that you want. So that's still being in the preclinical stages, which has not really gone into extensive phase 3 clinical trials, but we know that the CRISPR-mediated genome editing has reached phase 1 clinical trials. And this report in the New England Journal of Medicine, which was published less than a year ago, describes two patients, one with a sickle cell disease, one with beta thalassemia, who have been successfully treated with genome editing technologies for beta thalassemia. So the future is not that dark. Gene therapy will become available as a standard cure, and genome editing might also be available as a cure for patients with thalassemia, at least in the developed world.
Yeah, thank you, Sajid. Yeah, I think both transplant and gene therapy appear very expensive options if they're done in the private sector, but there is hope for the future. So I think we have come to the last point where I think this is probably the most important message that we can give today about prevention of thalassemia. So I think both Sevandi and Anuja both can jointly do this. So Sevandi, if you can talk about what you do for prevention, about issuing cards, screening programs, counseling, marriage counseling, all that, I think Anuja also can join in the conversation. Yes?
Yes, prevention of thalassemia is currently kind of the must in order to prevent reducing the disease burden. Because in the post-war and pre-COVID era, it is the management of thalassemia majors that consumed one of the highest proportions of the health budget of this country. So in order to reduce that, we have to stop thalassemia major patients being born. So the only way of doing that is by not allowing or preventing thalassemia carriers getting married and having family, giving rise to thalassemia major births. So in order to do that, the Ministry of Health has designed this National Thalassemia Screening Program. It is done in collaboration with the hematologists as well as the other physicians as well as pediatricians involved in the thalassemia care in this country. So in this protocol, we target the population of the age above 15 years. This is the premarital population. We need to catch them before they get married and start having family, start having children. So that's why we have selected this target group above 15 years. It is a voluntary thing. It's not a must or compulsory thing. We target the school children mainly, but in high prevalent areas, other institutions such as higher education institutions and employment institutions also get their employees screened for thalassemia carrier states. So we do it by a full blood count, start with a full blood count and end with a HPLC for the confirmation. We issue 3 types of cards and also counseling for those who are found to be positive. This card, the green card with an yellow border. This is issued for those who have a normal full blood count. They are exempted from going ahead to do a HPLC for the confirmation of thalassemias. They are excluded from going ahead in the process because they have a near normal red cell indices in the full blood count. But there are a certain amount of rare hemoglobinopathies as well as alpha thalassemias that are not seen by not excluded by a normal full blood count. Those patients will not be excluded by having this card. And this card, the green card with a green border. This is issued after performing HPLC and when the HPLC is normal. By this, the occurrence of beta thalassemia trait and most other hemoglobinopathies is very minimum if you are issued this card, because you have been undergone an HPLC before issuing this card. And this is the pink card. Pink card is issued for beta thalassemia carriers as well as any other hemoglobinopathies which we find in their HPLC. The main thing is, if you have a green card, you have diagnosed with one of those hemoglobinopathies as a carrier, maybe a homozygous state. Those patients who have a pink card should get married with someone having this card, the card, green card with a green border only. If you want to get married to someone having this card, the green card with an yellow border, you have to get your partner screened with an HPLC and get this card, the green card with a green border. So that's what is done by the population screening. It is not kind of well established, but it has its effects. According to the data at the National Thalassemia Center, Kurunegala, which screen more than 30,000 people annually and detect about 1,500 to 2,000 carriers every year, they have their results that they have reduced the number of thalassemia major births from 40 to around 10 to 12 per year in the recent past after starting population screening. But unfortunately, it is not very well carried out in other parts of the country because of lack of resources and manpower. At Hambantota, we could do it only for 1 month during February 2020 before the pandemic, and then we had to stop. Now screening is not being carried out in many parts of the country. These were the national statistics for 2018 and 2019 for population screening of thalassemias. But only thing, this service is offered for any person at any hematology clinic all over the country. So we are ready. It is kind of a walk-in facility. If you want to get yourself tested for thalassemia, you can come to the nearest hematologist. And also in all areas of the country, the general practitioners or the OPD doctors or doctors who see, the primary care doctors who see patients first are well aware of this condition, and they usually screen you. When they encounter a full blood count that is suspected of thalassemia, they refer you for further investigations to the nearest hematologist. And all hematologists have a pathway of sending their samples for confirmatory testing. So it's not a matter of going into a thalassemia center or a specialized center with all the facilities or to Colombo, but you can go to any hematology clinic in the country or maybe any OPD or any doctor in the country and tell that you want to get yourself tested for thalassemia. Then you will go in this pathway to get yourself screened, and you will be issued a card. So my message today is to prevent thalassemia major patients being born by safe marriage. So for that, we have to screen ourselves as well as our partners, to make sure that we don't have these common hemoglobinopathies. Of course, there are rare ones, that especially alpha thalassemia, that will not be detected by any test or any symptom at the carrier stage, but only be detected from genetic testing. Apart from that, but the country's major burden is managing beta thalassemia major patients. To reduce that burden, we can at least help to reduce beta thalassemia occurrence, major occurrence, by successfully carrying out this screening program.
Thank you, Seuwan. Do you like to say anything, Anuj, on the prevention?
Yes, Damika, my answer or statement is actually, one is factual, the other is a bit philosophical. Well, your topic is, are we doing enough for thalassemia?
Yes.
And the first statement is that thalassemia remains a neglected disease in Sri Lanka, partly because thalassemia's, I started by saying that we have only 2,000 patients in this country. Now, in a population of 22 million, when you say only 2,000 patients, I suppose everybody would underestimate the burden of disease, how much of an economic impact this disease has. Now, a very recent cost estimate suggested that per patient management costs the government $2,400 US per year, which essentially is about, leave the fluctuation aside, about 500,000 rupees per patient per year. So if patients live longer, obviously the cost is going to go higher. And if we don't prevent new births, which happen at the rate of about 60 new births per year, which has not really come down very much based on a recent survey done by us and published. We are actually spending about 7% of our annual health budget on the management of just 2,000 patients. Now, the problem with this is that the government or the health ministry is not actually aware of how this is happening, because this 2,400, you might be surprised by this. When you say $2,400 US is spent on thalassemia, and I say that the health ministry is not aware about this, and actually very frank about this, because this cost is not directly for thalassemia patients. It's going to the blood bank for screening for blood products, and it's actually hidden cost, but it is going because of the thalassemia patients. And so there is no doubt that you have to prevent. If you don't prevent, the cost is going to go up. And for only 2,000 patients, when you compare the numbers, for example, Thailand has 500,000 patients. India, in a country where there's hardly any proper data, they have about 250,000 patients. We have only 2,000 patients, and that costs 500,000 rupees per patient per year. So there's no question we have to prevent. Now, there are only two methods to prevent thalassemia. There is what Seuwan refers to, which is dissuasion of marriages between carriers, and then, of course, prenatal diagnosis and termination of pregnancy. Now, discouraging marriages alone, this is where it becomes philosophical, has never really worked in any part of the world by itself. Now, the only successful programs in any part of the world has been where dissuasion of marriage, education, counseling has linked up with prenatal diagnosis and termination of pregnancy. Now, this is the experience of Cyprus, of Italy, of Greece, of Iran, of Thailand, and a little bit in the Maldives. But we can't go there yet. We are, in a different society, different century, to be honest. So we got to do with what we have, and that's what we are trying to do. But even that, we are not doing it right. Kurunagal has been doing a great job for a long time, but it's kind of a stop and a start, and we are not doing it right. This word thalassemia, you listen to a television program on thalassemia, the presenters get the word wrong. So the word has not got, in Sinhala, janagata vela naha, samajagata vela naha. So it's way better than what it was 20 years 20 years ago, but a lot more needs to be done. We are still struggling at the very basics, of trying to prevent the disease, and the need is there. But I think, coming back to your original question, we are certainly nowhere near. The number of people who are interested in disease amongst the medical community is so little, and it is, to be honest, a losing battle, and that's my opinion.
Yeah, I think so. Our original question, are we doing enough? So at the end of the discussion today, I think we are convinced that we are not doing enough. And I think it is partly because as medical professionals, we don't emphasize the importance of knowing that either. So do you agree that, Anuja, we have to do more in educating medical students, our professionals, medical officers about thalassemia, pushing people to get screening programs into their hand? So
absolutely. See, the thing is, it is the commonest monogenic disease, and it is, in one of the things is that in the health structure, and I suppose in many developing countries, the strategy of health budget allocation is to let the funds tackle the biggest health issue. Right now, for example, it's COVID, or it would be dengue. We don't finance the smaller diseases. For example, if we, I'm not a health economist, so nobody should be listening to me. But if we sort out thalassemia, which is costing 7% of the health budget, this is, I'm not making up these numbers. This was calculated and we published this data. This is a number which we can actually put a stop to. Maybe not in one day, but over a period of time. That would save a lot of money for the government to spend on other diseases and improve the quality of the life of the existing thalassemia patients. Yeah. So we are approaching the top. We are not really ever looking at the bottom. Patients, when you look at the number of diseases, we are always looking at the bigger burden diseases rather than the diseases where the burden or the numbers are low. So we have to start rethinking our health strategies. And from simple academics point of view, we certainly have to re-emphasize this more and, do more and more rather than just limiting ourselves to, for example, very few internal medicine physicians would ever join a meeting on thalassemia. When these patients, adult patients, which is about 60% of thalassemia patients now in this country are over the age of 12 years. When they fall sick and when they go to an adult physician, most of them would be struggling because all they know is about chelation and blood transfusion. That's about it. Pediatricians know about this because they have been trained, but that's where we are. So there's a lot more to do.
Yeah, I think it's very important to educate medical students as well, because soon after tutorials, whole lot of young medical students come for screening, because that's another way of giving the message. So yeah, I think I hope we have managed to convince the listeners about the importance of thalassemia and how very little we do. And Anuja, you wanted to share your sickle work with us as well, right?
Oh yes. This is actually a tribute to one of your academics in Sri Lanka. I don't know whether he's even online today. Beginning of my talk, I was mentioning how sickle was described by Professor C.C. De Silva and his team in 1960. And he essentially said that sickle in Sri Lanka must have come from the Africans. And ever since then, the theory of sickle being of African origin, the sickle in Sri Lanka being of African origin, was the one which was taught to generations of medical students and everybody. And first scientific basis that this was not true was actually the PhD done by one of your Sri Lanka academics, Tamal Darshana. He published his PhD, I think, just about a year ago, where he did an elegant work where he studied, I think everyone helped in this project. Some of your patients were also part of this work. And he essentially studied about 60, almost all the sickle patients in the country he could lay his hands on. He traveled around the country and basically did I helped with the clinical work, but almost all the genetic work was done by him. So essentially proved that sickle is Indo-Arabic. Surprise, surprise, it is more likely to be that. But and he also realized that there were about 20% of our sicklers were homozygous, SS, and that was actually a surprise because this is sickle cell disease, though the numbers are not in the hundreds, is another very much underestimated disease, underplayed, downplayed disease. I'm sure everyone knows a lot about this.
Yes. Right. So I think we have come to the end of our session, and I'm very thankful again to the Staff Development Committee for allowing me to create this platform, which end of the day will give a lot of knowledge to the listeners. And I hope we convinced you to study more about thalassemia and to look into the problem more at every level, medical student, GP, physician, nurse, MLT at any level. So thank you very much to the three speakers who did a great job. And I'm sorry there was a problem with connection, but I hope we were able to kind of carry on properly. So thank you again for taking part in this session. Sajid?
Thank you, Madam. Thank you all the resource persons for that excellent presentations. We are very much thankful on behalf of the Staff Development Committee for accepting our invitation and coming and distributing your knowledge, expert knowledge on thalassemia. Thank you very much again. And this recording will be available on the faculty YouTube channel, Faculty of Medical Sciences, USJ, in a few days' time.
Okay, thank you.